Dr. Prashant, please unshare your presentation, Prashant. Dr. Rajeev sir, good evening, sir. Prashant, you'll be presenting second. So, good evening, friends. It's 8 o'clock. Warm welcome to the invited faculty for the day. Dr. Love Luthra. Dr. Love Luthra is from Ludhiana. He has his own vascular center, Chand Vascular Center. And then he also is associated with few other vascular surgery corporate hospital attachments. Sir has done his MCH from Ramya Medical College, Bangalore. And he's right now practicing at Ludhiana. And he has also have both DNB and DRNB in the respective subspecialties. Warm welcome to Dr. Love Luthra, sir. And he has been kindly contributed by Professor Iman Chip. He is from AIMS, Bathinda. Thank you, sir. Thank you for considering to join as a faculty for our program. And I also warmly welcome Professor Mukesh Suvera. I could see Dr. Rajeev Sahai and other senior faculty who have joined for the evening. So we have two postgraduates.
Sir, good evening, sir.
Dr. Nima. Good evening, sir. Good evening. Dr. Rima Mandal has been kindly permitted to present a case by Professor Swagata Brahmachari. Madam is the professor and head of the department at AIMS Bhopal. And we have Dr. Prashant, again a senior resident from the Government Stanley Medical College Hospital, kindly permitted by Dr. Anandi ma'am as well as Dr. Gayatri ma'am to present a case here. And I also warmly welcome all the faculty and the students who have joined, both in the Zoom as well as in the YouTube. So, warm welcome to all of you. And without much ado, we will start. Dr. Luthra, you are welcome to take over. And Dr. Rima, you can switch on your video and share your PowerPoint. Please introduce yourself. You are head of the unit, you are head of the department, and start your presentation. Good luck to you.
Thank you, sir. Good evening, respected seniors. I am Dr. Rima Mandal. I am a third year general surgery resident in the in AIMS Bhopal, and my mentor for this session is Dr. Swagata Brahmachari ma'am, additional professor, Department of General Surgery, AIMS Bhopal, and our head of the department is Dr. Pradeep Saxena sir, and from AIMS Bhopal. So, good evening to everyone, sir. Should I start with the presentation, sir?
Give me a moment. Dr. Luthra, are you with us? Kanna sir, good evening, sir. Give me a moment, I think, Dr. Luthra. Good evening, sir. You are somewhere else from your home, sir?
I'm at the airport, Dr. Kanagavel.
Oh, okay. You are traveling or coming back, sir?
No, I'm going to Kolkata.
Okay. For the West Bengal chapter meeting, sir?
No, it is the actually Western meeting at Sonnet Hotel there at Kolkata for 2 days.
Actually, West Bengal chapter meeting is also happening this weekend, I believe, sir. Yes, sir.
Okay. So I'm going for a different meeting here.
Okay, sir. Okay. Dr. Love Luthra, you are okay? Welcome, Professor Nishikant. Dr. Luthra, sir, you are comfortable now? Can we start the session? You please unmute yourself, sir.
Yes, sir. Please go ahead, sir.
Sir, good evening, sir.
Dr. Rima, sorry for making you wait. Please start your presentation. Welcome, Professor Gujar. Good evening, sir.
Good evening, sir.
Sir, shall I start, sir?
Please, ma, please. Good luck.
Thank you, sir. Good evening, everyone. Today I'm going to present a case on peripheral arterial diseases.
Go ahead, ma. Go ahead.
Presenting a 35-year-old gentleman from Sagar, Madhya Pradesh, who works as a teacher, who presented with chief complaints of pain in bilateral lower limbs for 6 months, increase in the pain in the right lower limb for 1 week, weakness in the right foot for 1 week, blackish discoloration in the right lower limb for 5 days. Coming to the history of presenting illness, patient was apparently asymptomatic 6 months back when he developed intermittent pain in his bilateral lower limbs, which used to occur in the morning and then resolved spontaneously throughout the day. There is a history of acute increase in the pain in his right foot for the last 7 days, history of weakness in the right lower limb since 7 days, history of swelling in the right lower limb for 7 days, which progressed from his foot to the knee. History of fever episodes for the last 6 days. History of blackish discoloration of the right lower limb for the last 5 days, which started from the foot and progressed upwards till the upper 1/3 of the leg, right leg. It was associated with foul-smelling discharge for the last 4 days. History of few episodes of dizziness during the onset of the symptoms. There is no history of decreased urine output or breathing difficulty, no history of trauma to the right lower limb or any history of unknown bite, no history of diurnal variation of the leg swelling, no history of syncope, blackouts, chest pain, palpitations, no history of impotence, no history of color change of the limbs on exposure to cold. Coming to past history, patient is not a known case of diabetes mellitus, hypertension, tuberculosis, thyroid disorders. No past surgical history. There is no history of stroke or any cardiovascular events. Personal history. Patient has history of smoking bidi and chewing tobacco daily for the last 15 years. No history of consumption of alcohol. Patient has normal bowel bladder habits. Patient is non-vegetarian by diet and has a normal appetite. There is no significant family history or no similar illnesses in the family. Summarizing my history, a 35-year-old gentleman with history of claudication pain in bilateral lower limbs for 6 months with acute increase in the pain and swelling in the right lower limb for 7 days, followed by progressively increasing blackish discoloration and foul-smelling discharge from the right lower limb. Shall I proceed to examination, sir?
I have a few questions. In your, can
Dr. Luthra,
I?
one moment, sir. You can go back to the slides and revisit the slides also. Go back to the first slide, Dr. Rima. Someone seems to be cooking something actively. I'm sorry about that. Go to the first slide, Dr. Rima, and Dr. Luthra and other faculty can revisit your slides. Next slide, next slide. Dr. Luthra, please take over.
Yes. Dr. Rima, my first question is, in the chief complaints, you told that for the past 6 months, the patient has pain in bilateral lower limbs.
Yes,
okay,
sir.
And it has increased since past 1 week. Regarding when you explained your chief complaint, okay, what was the one important thing that you've not mentioned in your present history is that whether it was calf claudication, it was thigh claudication, it was buttock claudication. One thing, the level of claudication, and what was his claudication distance?
Yes, sir, he did not specifically mention claudication distance, sir. He said that the pain used to occur early in the morning, and while he worked throughout the day, the pain used to decrease.
Then
So,
this is not, then how do you define what is claudication pain?
claudication pain is, sir, the claudication pain which occurs on exertion and then it relieves like after walking or maybe after taking rest, depending on the Boyd's classification.
What is definition of Rima? Again, repeat again definition of, sorry,
Yes, please. Can you
definition
please
of
define
claudication.
claudication pain? Yeah.
Claudication pain is a cramping type of pain which occurs after the
What is
exertion of the
claudication
muscle.
then? Wait, madam. What is claudication?
A cramping type of pain, sir, which occurs
Definition,
due.
sir is asking definition. Claudication is a cramp-like pain felt in a specific muscle group due to deprivation of blood supply. This is the definition. And claudication distance is distance at which patient experiences the pain.
First
After
time
taking the rest, patient can able to walk same distance, that is called as claudication distance.
So, as per this is the exact definition, but you're presenting complaints. The chief complaints, you were saying that patient has pain in the morning when he gets up, but when he walks, the pain is relieved. This is absolutely not a claudication pain then.
Yes.
Ideally, it should have been that the pain starts, and like sir mentioned, there is a specific group of muscle that is involved, because that is very important to know, because with the specific group of muscle that the patient tells you whether he can have a calf claudication or a thigh claudication, that actually explains you the level of occlusion. If the patient is having calf claudication, then the level of occlusion is proximal to the claudication muscle. Exactly. So if your patient is having calf, it is very important to ask in the history. One, I think your chief complaints and your present history are not matching as per your diagnosis.
Excuse me, may I come in, please? Doctor, I'm acquainted in biohistory. Have you been able to decide whether this is an arterial case or a venous case or a neurological case? Biohistory, you should be able to differentiate between the three.
Yes, sir. This is most probably an
So what is
arterial
your case? Is it an arterial case or a venous case?
It's an arterial case, sir. So it's an arterial case because patient
So what are the characteristics of an arterial case? What is the characteristics of an arterial case?
In arterial case, patients will have the relief of the claudication pain after taking rest or after continuing his activity.
Right. So there will be pain. Right. So there will be pain on exertion, and the pain will go away once he stops.
Yes,
only
sir.
to reoccur when he starts walking again.
Yes,
Does
sir.
he have this? Okay.
He has, sir, it can be, sir, Boyd classification 1, where on keeping on walking, the pain reduces.
Okay. Then why is he having blackening of foot?
Sir, he is having
You think
acute.
Boyd's one will have blackening of foot?
There is some acute phenomenon which is superimposing on the chronic limb
What
ischemia.
acute phenomenon? What acute phenomenon? What acute phenomenon?
It can be an embolic
You said
phenomenon,
the patient is having fever.
Yes, sir.
You said the patient is having fever. So there is some element of infection there?
Yes, sir.
Right. So what is your diagnosis by your history?
It's a peripheral acute limb ischemia due to peripheral arterial disease, which can be secondary to Berger's disease, sir.
Okay. Sir, please, sir. Sorry, I intervened. Sir, please. Hello.
Rima, where is the pain?
Sir, pain initially when he used the pain initially started in his foot. when in the acute phase, in the last 7 days, it gradually it started in his foot and then it gradually progressed till the knee.
Towards knee.
Yes, sir. And in the initial 6 months,
pain
he
is
gave
increased in
history
the
that,
morning.
sir, pardon, sir.
Here is bilateral lower limbs which used to occurs in the morning. Pain in the bilateral lower limbs which used to occurs in the morning and resolve spontaneously.
Yes, sir. That's for
What
6
does this
months. He used
signify?
to have pain in entire he said that he has pain in his entire bilateral lower limbs.
Okay, there is no history regarding claudication distance or all these things.
No, he did not give specific history about claudication distance, sir.
Okay.
Can I please come in, ma'am? Actually, the thing is that you've tried to mix up everything in one situation. Okay, is this patient a real one, or you've made a history? Is
Sir,
it a dummy
real
case or is a real case?
real case, sir.
Okay, so the thing is, like you started with chief complaints of pain in both lower limbs since 4 months. Okay, and now your main complaint that you are presenting is that the pain has increased in the right foot for the past 7 days. And from your history, you have come up with a diagnosis. Your provisional diagnosis is it is an acute limb ischemia. Okay.
Yes, sir.
And the underlying cause is peripheral vascular disease. This is not an acceptable diagnosis. Acute limb ischemia is itself peripheral vascular disease. Okay. So the underlying cause will always be an pathology, will be a pathology. It can either be age-related atherosclerosis, it can be, acute embolic phenomena, it can because of atrial fibrillation. So your cause of that acute limb ischemia is not peripheral vascular disease. Okay, so I think either you present it as a case of critical limb ischemia. If the patient is admitted with acute pain, then you have to mention about the rest pain. Acute limb ischemia is an sudden onset limb. It is, a deteriorating limb, and it is a condition that requires urgent surgery. You cannot wait for an acute limb ischemia. Medical management is not the treatment. So, in case you are diagnosing it as a case of acute limb ischemia, your chief complaint would have been that patient was admitted with severe pain and discoloration in the right foot. Okay, since last 7 days, and that discoloration has progressed, and the patient is having rest pain. That would have been your chief complaint in such a scenario, as per your provisional diagnosis. And in your history of present illness, he's a smoker. He had complaints of pain in both the lower limbs, claudication pain since 4 months. He continued to smoke. Okay, and then you have to specify, you have to ask the patient what is the distance when he gets pain. Okay, patient will not tell you that I walk for 100 steps and then there is pain in my calf. These are leading questions that you have to ask the patient. Okay, yes, it can be a
Yeah.
chronic limb ischemia, a peripheral vascular disease, a chronic disease that is progressing gradually, and he has been having claudication pain for the past 4 to 5 months. He still continues to smoke. His distance will gradually decrease. 4 months back, supposedly he was walking for around 100 meters, and in the last 20 days, the distance drastically reduced to around only 40 or 30 or 40 steps. And yes, there is because he is a smoker. Smoking is one of the most important causes of atherosclerosis. Okay, and it must be a BD smoker. Okay, then you have to specify the number of cigarettes he's smoking or BDs he's smoking. He's a tobacco chewer. And then because of that, probably it led to an embolic phenomena. There was a plaque in his proximal arteries that got ruptured, and now it has occluded the vessels in the right leg. So this is how you have to proceed. Okay, if you are diagnosing it, if your final diagnosis is going to be in case of acute limb ischemia with rest pain, your chief complaints are going to be rest pain since last 7 days with discoloration. These are your chief complaints. Your complaints are not going to be claudication pain for the past 4 months. That will come in your detailed present history.
Yes.
Okay. And now
Yes.
you've also in your present history, you've mentioned, yes, there is swelling in the right lower limb that has involved almost the entire leg. Exactly. It is a clinical finding when your limb, because the window period is 6 to 10 hours, okay, of acute limb ischemia. The muscles start to die within 6 hours of ischemia. Okay. Now there is discoloration of the foot. There is swelling. Probably he has ischemic changes. He's ending up in ischemic injury. There is some kind of secondary infection, cellulitis. But I think then you have to modify your chief complaints if you have a particular diagnosis. He may have presented to you with rest pain and sudden onset since last 4 to 5 days, 7 days, acute limb ischemia. Okay, so that is going to be your chief complaint, and then the present history will involve everything what has been happening to him for the past 4 to 5 months.
Yes, sir.
Okay, fine. Thank you.
Shall I proceed to the examinations?
Go to previous slide. Wait, there is history of acute increase. Next, there is weakness. Next slide. Why you ask history of fever in this patient, or why you ask history of episodes of dizziness?
Sir, for to rule out, sir, sepsis. If in sepsis, patient can have fever and then altered sensorium to because he is having a source of infection. So to rule out sepsis.
Okay.
Also, dizziness can be it can be associated with syncope, like transient ischemic attack, which can like show an embolic phenomenon, which can be like causing this phenomenon of peripheral arterial disease as well.
Next
So
slide.
acute limb ischemia is this phenomenon of acute limb ischemia.
Next slide, please.
Yes.
Okay, no history of syncope, blackout. Why blackout, chest pain, and palpitation?
Chest pain, palpitation. This is to rule out any cardiovascular events which can produce an emboli, which can again cause acute limb ischemia. Similarly, syncope and blackouts can also to rule out embolic phenomenon.
It is to rule out cardiac embolization, arterial fibrillation with embolization. Okay,
Yes.
why you ask history of importance?
Sir, if there is a Lerish syndrome, which in which there is clot, a clot which is present in the
What are the components of this
bifurcation.
lyric syndrome?
Sir, impotence. There is a claudication in the buttocks, claudication pain in the buttocks,
Bilateral buttock claudication.
bilateral buttock claudication.
Then buttock claudication, sexual impotence due to saddle-shaped embolus at the bifurcation of the hole.
Bifurcation of the
Okay. Next slide, please. So what is your conclusion by this history? This is due to Berger disease or something else?
It is due to Berger's disease, sir. The chronic limb ischemia which was occurring is due to Berger's disease, and this acute phenomenon can be an embolic phenomenon due to atherosclerosis.
Look, you can't have two pathologies. Don't get in two pathologies. That there's an embolism also on the
Just
Berger's.
now, sir, clear everything, madam. Rima. Just now, sir, clear everything.
Yes, sir, that smoking could have formed could have formed an embolus, which can precipitate this episode of acute limb ischemia, and that smoking itself can
Patient
be
is
the
having history of smoker. A patient is non-smoker here.
smoker. Yes, sir. Smoking, history of smoking
Where
is
you have
tobacco chewing.
mentioned
Smoker.
how much
Just
packs
okay,
per
okay,
day?
Dr. Mandal.
Pardon, sir?
Again,
Yes, sir.
I'll just come in. Ma'am, again, you are getting confused. Okay.
Yes.
See, smoking will never cause an embolus. An underlying
From this-
cardiac condition. See, acute limb ischemia is an embolic phenomenon. Okay. Now you are again getting confused between acute limb ischemia, Buerger's disease. Because he's a smoker, it is not that all the smokers will have Buerger's disease. Okay. Yes, he's a young patient. You very well studied the Buerger's disease criteria, young patient who is a BD smoker, tobacco chewer. But again, he has presented to you with acute limb ischemia, and you are saying that cardiovascular system, as per your history. See, acute limb ischemias are always caused by an embolus. Okay. Critical limb ischemias or chronic limb ischemia is a long-standing atherosclerotic pathology. There will be plaques in the vessels, usually seen in old age patients, patients who are diabetic, hypertensive. Yes, probably he's a BD smoker for the long duration. He will be having claudication symptoms. Then Buerger's disease will never cause acute limb ischemia. It is rest pain. Okay, there is discoloration, there is rest pain. Okay, then don't call it an acute limb ischemia. If you are classifying it as your Buerger's disease, as per your history, a young male who is a BD smoker, tobacco chewer, it is Buerger's disease. He had history of claudication pain, probably calf claudication, and that has, because he has continued to smoke, probably it has led to Buerger's component. Now, that is why we were specifying, sir also specified the level of claudication. This is a very important thing, whether it is calf claudication, okay, whether it is a thigh claudication, or these are symptoms of an acute limb ischemia if there is a saddle thrombus in the ioto-iliac bifurcation. So you have to be very specific with your history, because as per your history, we are not going towards any particular diagnosis. You are mixing everything, and you are trying to persuade us to get convinced that it is a Buerger's disease, but your history is not at all matching. You've already said it is an acute limb ischemia due to Buerger's disease. Buerger's disease never causes acute limb ischemia. It is an embolic phenomena. And the most common cause of embolus is atrial fibrillation. It comes from the heart. Okay.
Okay, Dr. Mondal, if you think it's is there a criteria for what is the criteria for coming to a diagnosis that this is Buerger's? Hello, can you hear me?
Yes, sir.
Yeah. What is your criteria on that it's Buerger's? We accept, okay, you say it's Buerger's with some event which has caused acute limb gangrene or whatever. Okay. What is the criteria for Buerger's?
Yeah, it is usually seen in young males and with a patient having history of smoking.
Young, how young?
Like is seen less than 40 years of age. This patient is 35 years
What is Shinoy's criteria? What is Shinoy's criteria? Have you heard of it, Shinoy criteria?
Cannot recall right now, sir.
Okay, so it's less than 50 years of age, right? Second? There has to be a history of smoking.
Yes, sir.
Third? Where is the obstruction in Buerger's?
It is usually seen in the peripheral, in the lower limb blood vessels like femoral or popliteal artery.
Where in the lower limb?
Pardon, sir?
Where in the lower limb? Which part of lower limb is from your groin down to the toes? It is infrapopliteal. Okay.
Yes, sir.
And here comes the level of claudication.
Yes. Pardon, sir?
And there'll be absence of atherosclerotic risk factors. There'll be absence other than smoking. There'll be no other risk factors for atherosclerosis in Buerger's. So the patient will, what are the other risk factors? Hypertension, hyperlipidemia, diabetes mellitus, all that will be absent. So now let's come to your patients. Is he fulfilling all these criteria or not?
Yes, sir.
So he has smoking, he's less than 50 years of age.
Yes, sir.
Is his symptoms really intrapopliteal?
He had mentioned that his pain being in the foot, in the ankle, sir.
Okay, so it is intrapopliteal, right?
Yes.
Now, does he have any other risk factors for
No, sir.
atherosclerosis?
No, sir.
So the criteria is being fulfilled,
Yes, sir.
right? Your history is actually, look, you should decide, once you take your history, you should come to a conclusion, okay, this is my differential. Then go back and ask the patient again to confirm, right? You just can't take the history in one go and come to a diagnosis, okay, it could be this or it could be that. You go back and take the history again and confirm whether it's going to fall to your diagnosis, right?
Yes, sir.
So please, sir.
Absolutely right, sir. So we've already discussed the criteria, and like sir said, the criteria fits in typically as all the characteristics of Burgess are included in your history. So when we asked you what is your provisional diagnosis, your provisional diagnosis should have been as per my history and everything. The provisional diagnosis is patient is having rest pain and underlying pathology is Burgess disease, because none of the other criteria to so you mentioned acute limb ischemia, so please don't mention acute limb ischemia. It is rest pain with Burgess disease as per your history and your clinical assessment in the history. Okay, so you always have to be sure that peripheral vascular disease has two components, one acute limb ischemia and the other is chronic limb ischemia. And chronic limb ischemia, the underlying pathologies can be obviously smoking, age, smoking, okay, hypertension, diabetes, and hypercholesteremia.
Hyperlipidemia.
Yeah, okay. So as per all your positive findings, your provisional diagnosis comes to Burgess disease. So do not use that. I can understand. We can get confused because he's come to you with sudden pain and, suspecting acute limb ischemia is one of the provisional diagnoses. Yes, you have to rule it out. Okay. But then we've already mentioned that there is no dizziness, no history of TIA, no history of palpitations. So probably you've ruled out atrial fibrillation clinically with your history. Rest everything will be now, all these findings will be confirmed in your clinical examination, your inspection, palpation, and auscultation, and that is going to take you to your final diagnosis.
Yes, sir.
Okay, fine. Please carry on, please.
Coming to examination, the patient is conscious and oriented. Informed consent was taken from the patient. The patient was examined in a well-lit room and exposed from umbilicus to his right bilateral lower limb foot. The vitals of the patients were pulse was 112 per minute recorded in the right radial artery. The pulse was regular in rhythm, normal volume, normal character with no radial or radiofemoral delay. Blood pressure was 132 by 80 millimeter of mercury, which was recorded in the right brachial artery in sitting position. The temperature of the patient was 98.7 degree Fahrenheit. The saturation was 98% on room air. BMI was 23.5 kg per meter square. ECOG score was 3. The patient did not have any pallor or icterus, no cyanosis, no clubbing, no generalized lymphadenopathy. Right lower limb pedal edema was present. Coming to local examination of the right lower limb, patient had purplish black discoloration of the right lower limb involving the foot and which extended till 6 centimeter distal from the right knee. There was circumferential blackish discoloration of the right lower limb extending from the foot to the lower one third of the leg and blackish discoloration in the anterolateral aspect in the upper 2/3 of the leg, which was associated with foul-smelling discharge. Pitting edema tenderness was present from the foot to the upper 1/3 of the leg. The right lower limb was cold to touch. Shriveling of the distal phalanges of the first and second toes of the right lower limb are present. There is loss of hair in the right leg. There is a ruptured blister of size 4 × 3 centimeter in the lateral aspect of the mid leg. The left lower limb on examination was normal. This shows the clinical pictures. So he has blackish discoloration, which is extending from the foot to the around 6 centimeter from the distal to the right knee, and he has circumferential blackish discoloration in the distal from foot and to the distal 1/3 of the leg, and blackish discoloration in the anterolateral aspect in the upper part of the leg. The sole of the entire sole of the foot is involved. This also shows that there was also the shriveling of the distal phalanges of the first and the second toes of the right lower. On sensory motor examination of bilateral lower limbs, the power of right lower limb at the hip joint was 5/5. In the left, it was 5/5. In knee joint, it was 5/5 in right lower limb. Left also 5/5. At ankle, patient was unable to move his ankle joint or his toes. So power was 0 in his right lower limb, in the ankle and the toes. And sorry, sir. In the left lower limb, his power of ankle and toes was 5/5. On sensations, right lower limb at the thighs, and it was normal sensation. And left lower limb, there were normal sensations in the thigh, and sensations were decreased in the leg and foot of the right lower limb, but in the left lower limb it was all normal. Sorry, sir, I mean present typing mistake. Coming to examination of peripheral pulses of the lower limbs. On the right lower limb, the common femoral artery was palpable, but the pulses were feeble. In the left, it was normal. Popliteal artery, right lower limb, it was not palpable. The popliteal artery, anterior tibial artery, posterior tibial artery, and dorsalis pedis artery. None of the arteries were palpable in the right lower limb. In the left lower limb, all of them were palpable and had normal volume. Coming to the summary of the case, it's a 35-year-old gentleman with history of claudication pain in bilateral lower limb, with acute increase in the pain and swelling for the 7 days in the right lower limb, followed by progressive increase in the blackish discoloration and foul smelling discharge from the right lower limb. On examination, patient has tachycardia with wet gangrene of right lower limb involving the right foot and the lower 2/3 of the leg. Patient has feeble pulse at the common femoral artery, with the other distal peripheral pulses being absent in the right lower limb.
Dr. Mandal, I have got very strong reservation about your examinations. You have gone straight away to examine the right leg. Aren't you supposed to compare both the legs both the lower limbs before you do and start off? You have not told us anything about the left limb.
Left lower limb was normal on examination.
No. Compared to the right, is the girth the same? Is the length same? Is the color same? Are the integumentary systems the same? The hair, the skin, the temperature? You have to give us the whole picture. And this doesn't look like TAO by the picture. This looks more like it could be soft tissue necrosis or synergistic infection.
And can I? Yeah, please, sir, please go ahead. See, now you're
examining the pulses right at the end. Aren't you supposed to go and examine the pulses before you examine sensation and temperature and reflexes and vibration?
Yes, sir.
Rima, what is the order of examination for peripheral disease? On inspection, which point supposed to ask? On palpation, which point? I am asking very basic question. What is order of examination?
Sir, on inspection, we will see if there is we will see if there is edema, if there is any color change in the limbs, if like if pallor or cyanosis is there, or there is any blackish discoloration is there, any foul smelling discharge is there, then smoothening of skin or a loss of hair, uh, drying, then shriveling of the nails, brittle nails are present.
That comes under chronic signs of the chronic lower limb ischemia. That is, it comes under only one heading: signs of the chronic lower limb ischemia.
Can I come
Other
in?
points: muscle wasting, attitude
Yes,
of
the
limb,
girth of
venous
the
guttering,
attitude of the
skin
limb,
color
and
of
the
limb.
girth of the muscle should also be seen, sir.
But you have not mentioned it. Okay.
Yeah, I'll just add a few things because see now whatever history you've given, now we compare your chief complaints, your HOPI, and now your clinical evaluation. And after seeing the picture, okay, like sir asked you, what are the signs of chronic limb ischemia? Okay, there is muscle wasting. You yourself told there is brittleness of the nails. So that classically explains a critical limb ischemia, chronic limb ischemia that has been progressing gradually, okay, over time, and the affected limb will always be thinner. There is loss of muscle girth. There will be brittleness of nails. Now, in our scenario, in this case, if we look at the limb, you compare both the limbs, the left limb looks absolutely normal. The temperatures are normal. The ankle toe movements are there. Okay. Now, in this case, there is discoloration that is progressing towards the knee. And you've mentioned that the common femoral pulse is feeble. So,
Yes,
in
sir.
your examination, you yourself ruled out Berger's disease. Okay. It is a proximal disease. Okay. And now it is an classical case of acute limb ischemia. Patient was absolutely fine 7 days back. He was having claudication pain since 6 months. All of a sudden, in 7 days, he had a severe pain in the right foot that was associated with coldness. Okay, that progressed actually to cyanosis and eventually to gangrene. Because the muscles are dying, he has now got secondary infection because of ischemia. There is no flow in the leg and there is ischemic muscle injury. And on your palpation, another important thing you forgot to mention was that the calf tenderness. I am 100% sure if you press both the calves, patient will have severe pain in the right calf because it is an acute ischemia because of lack of blood supply to the limb and your femoral pulse is feeble. It means there is some lesion proximal to the common femoral artery. You have all the palpable pulses on the left leg. Your
Sir.
left foot ankle toe movements are present. The temperature is cold. Although he's probably, you may get a feeble pulse in the left leg because of his chronic history. Okay. But now in the right leg, you are getting a feeble femoral pulse. All the rest pulses are absent. You are not palpable. There is blackish discoloration. There are signs of a dying limb. Okay. You mentioned that there was a blister that ruptured.
Yes, sir.
So this is a classical acute limb ischemia who has presented to you in your clinic or hospital in a delayed phase. Okay, he had probably symptoms 3 or 4 days back, and then he visited you when he started noticing those color changes in the foot. His pain was unbearable. He was not able to sleep, and he starting ending in cellular sepsis because of that ischemic insult. Okay, so it is very important in your examination now that you compare both the limbs because it is always in any kind of vascular disease, you have always have to discuss the normal limb first. You have to compare it during your inspection, and then you have to confirm your inspectory findings during your palpation. Okay. Now, in your palpation, you've seen that the limb is cold. Okay, there is blackish discoloration. There are no ankle toe movements. He has a history of blister that got ruptured. So he is in ischemic insult now. The limb is almost dying. It is almost dead. Okay. So that is why I was stressing on one point. If it is a chronic disease, the claudication level, the calf, whether it is at the level of calf or the thigh or the buttock, it is very important. I am 100% sure this patient, like you mentioned in your history, he complained of pain in the whole leg. It means there is some pathology proximal to common femoral, maybe in the iliacs or the common iliac artery on the right side. That is why he's having that thigh and leg claudication, leg pain actually. Okay. Now, once you recall your clinical findings, okay, and then you go back to your history, like sir mentioned, in one go, it is never possible to diagnose any disease. You always have to keep differential diagnosis in your mind. Okay, you have to make a provisional diagnosis after your history is completed, and then that is going to get confirmed with your clinical evaluation. And then once that is done, you have a fixed diagnosis. You investigations are just to confirm your diagnosis. Okay.
Yes, sir.
So I think if you recall your case, okay, the history is good. You've almost covered everything in the examination. You've missed a few basic points, but that is very well given in SDAS in that chapter of peripheral vascular disease, arterial disease. Okay. Uh, what points you have to see in the inspection, because the girth of the muscles, the look of the limb, everything is very important. And then in your palpation, what do you have to see? All those signs, whether according to you it is cellulitis, according to you it is a dying limb, or it is a typical limb of Burgess disease with severe rest pain. A Burgess disease patient will never ever come to you like this. It is an absolutely ischemic limb. And I'm 100% sure when we proceed towards your investigations, you are going to share your investigations. There is a proximal lesion, and it is probably a thrombus.
Yes, sir.
Okay, so we'll proceed with it. Okay, okay, fine.
Uh, this is the right lower limb and CT angiography of the patient, sir, which shows that non-contrast opacification of the right common iliac artery, external and internal iliac artery, common femoral artery, anterior tibial and posterior tibial and dorsalis pedis artery, non-contrast opacification of non-contrast opacification of left. This is an outside CT angio, which is reported as like this: non-contrast opacification of left external iliac, common femoral part of the superficial femoral artery. And on our exam, on our CT scan, there is complete occlusion of the right peroneal trunk, non-contrast opacification of the right common iliac artery, external iliac artery, common femoral and proximal part of SFA, and complete occlusion of the right tibio-peroneal trunk, anterior tibial artery, peroneal artery, posterior tibial artery, and dorsalis pedis artery. Non-contrast opacification of left external iliac artery throughout its course, except for short segmental opacification of external iliac artery from its origin. There is also non-contrast opacification of left common femoral artery as well along its entire extent. Faint opacification of the anterior tibial artery, posterior tibial artery, peroneal and dorsalis pedis artery. We also got a venous Doppler to rule out this deep venous thrombosis. So, these are the, sir, I include only the imaging investigations, like not any blood investigations.
So that is what we were discussing. It is a classic case of acute limb ischemia. One most important investigation that we've missed here is ECG and
No.
his 2D echo. Okay. So we need to know the source of thrombus. It is an acute limb ischemia. Like we discussed, there is occlusion in the proximal arteries. The external iliac is almost completely occluded. There, at the bifurcation, there is a thrombus in the common iliac artery. Okay,
Yes, sir.
right side. As
Yes,
per
sir.
your clinical findings of the left lower limb, again, CT findings do not, match with your clinical assessment, because as per your clinical findings, all the pulses were palpable
Yes,
on the
sir.
left side. Yes, probably he'll be having some kind of chronic atherosclerotic component.
Collaterals.
Yeah, definitely collaterals. It is a chronic setup in the left leg, but in the right leg, that is our index limb. Because he's come to us, he's probably going to lose his right leg. Okay, most likely he's going to end up in above knee, because it
Yes.
is a delayed acute limb presentation. But the thing is, your above knee stump will only survive if you remove the thrombus. You will have to remove the thrombus. So CT has actually confirmed your clinical findings. That is what we all were discussing, that, like I said, in your provisional diagnosis, after your history, you had mixed up everything. Acute limb ischemia, Burgess disease. Okay. Because probably you had studied the case entirely. Okay. So what I am trying to say is, once your diagnosis changes with your examinations, okay, with your history, you have to fix my provisional diagnosis is probably a Burgess disease, because your history is telling he's a smoker. He's, he's in fulfilling all the criterias of Shenoy's criteria. So at that time, it would have been Burgess. After your clinical evaluation and, inspection, palpation, the Burgess component was completely removed, because the limb was acutely gone, ischemic. Okay. Secondly, secondly, the clinical evaluation told us that femoral pulse was feeble, so that doesn't fit your Burgess criteria. Okay, the color changes, the ischemic changes, the cellulitis, the gangrenous part doesn't fit again Burgess. Okay, now your diagnosis after your examination, it all of a sudden becomes, it is an acute limb ischemia. And then investigations, the CT angio and everything has confirmed us that it is an acute limb ischemia. So this is how you proceed. Okay, you've covered almost everything. It's just I can understand. Okay, uh, but the thing is, you have to make sure that we are covering all these aspects. See, at your level, we don't expect you to give us the 100% right criteria, but the way you are approaching the case, the way you are diagnosing the case, that becomes more important. Okay,
Yes, sir.
fine. So, what is going to be your after? Okay, now what is your final diagnosis, ma'am?
Acute limb ischemia, secondary to probably atherosclerosis. Atherosclerosis involving involving the common iliac artery, which has led to which has formed an embolus causing acute limb ischemia.
Beta, what is the cause of embolus? See, you said 34-year-old smoker, non-diabetic,
Atherosclerosis.
non-hypertensive, atherosclerosis in a 34-year-old who has no other comorbidity other than he's a smoker. He's non-diabetic, non-hypertensive. That is why I asked you, did you get a 2D echo of this patient done? Or ECG, did you see the ECG? Probably he is having AF. There is we need to find the source of thrombus, embolus.
Yes, sir.
Hmm?
We have not got a 2D echo done, sir. But ECG was done.
Yeah, so that is one very important investigation in our case. In such a scenario, we need to rule out whether he's having atrial fibrillation. Okay, because in AF with fast ventricular rates, this is the most common cause of an embolic phenomena. The embolus is always going to come from the heart.
Yes,
Okay.
sir.
any chronic plaque, yes, it can rupture. Okay, but it is very rarely that it is going to cause embolus. The embolus and all these emboli, always remember one thing, your CT is if you look at the films, you can see the right common iliac artery, but you cannot see the bifurcation of the right common iliac artery in the angio recon, the film that you would have seen. Okay, because all these emboli, they get obstructed at the bifurcation. They will never come in an artery. It will never come in an external artery. It is at the bifurcation of common iliac artery, at the mouth of where it is bifurcating into external and internal. Okay.
Yes.
So that is very important. So one very important investigation in today's cases, we have to evaluate him. You have to see the ECG. He's having tachycardia. Probably that is because of an ischemic insult. Okay, but we need to see the heart rate, whether it is fluctuating, and then you have to get an echo. You have to look for an embolus in the ventricle.
Yes.
Yeah, fine. Please go ahead.
For management, sir, I haven't added any slide, but for management, we should proceed with for this patient. Option we have is since patient has a septic foci, so to remove that, patient should undergo right above knee amputation. Sir.
Again, there is a thrombus, occlusion in
Yes,
the
sir.
common iliac artery, right external iliac artery. Okay. So even if you go ahead with the
Yes.
above knee amputation, do you think that your limb will, the stump will survive? There
No,
is
sir.
no
First,
flow in
initially he
the
has to undergo amputation, followed by some revascularization procedure after we
no.
remove the septic foci.
See, level of the limb below knee is almost gone.
Yes, sir.
You get me? Now the
Yes,
point
sir.
is, you cannot take this patient again and again for a surgery. Okay, you know that the limb is gone below knee. It is a non-salvageable limb. Okay, because of
Yes, sir.
delayed limb ischemia. Now the point is, yes, we know we are going to end up in above knee amputation. Through that, once you do your above knee amputation, you are going to take control of the superficial femoral artery. You are going to ligate it. Instead of giving a second incision, either in the, obviously you are going to open the groin. So it is always better. You've already counseled the patient for above knee amputation. You're going to take control of the superficial femoral artery. Okay.
Yes.
Here you can pass in your Fogarty catheter and you can just remove the thrombus. Unless you get the inflow, your stump is not going to survive.
Yes, sir.
You get my point?
Yes, sir. But there is block
Dr.
in the
Mandal,
common iliac artery also, so we might not be able to
You
access
will
that.
go. Ma'am, you will go from the superficial femoral artery. You get different sizes of Fogarty. Okay, and the length is around 150 to 200 centimeters. Instead of giving a separate incision in the groin to go to the iliac artery proximally, from your mid thigh above knee stump incision, the fish mouth incision we give, you can easily access the common iliac artery.
sir, may I come in, sir?
Yeah, please, sir.
Dr. Mandal, this is wet gangrene or dry gangrene?
So wet gangrene, sir.
So will you go in for amputation here
Yes, sir.
straight away? Why? What is the difference between wet gangrene and dry gangrene? What is the difference between wet gangrene and dry gangrene?
Sir, in wet gangrene, patient will have features of spreading cellulitis like tenderness, edema, foul smelling discharge, and this in dry gangrene, sir, patient will not have.
And Dr. Mandal, and skip lesions. What are skip lesions? What are skip lesions?
Like lesions which will have area of normal skin in between, sir. Normal vascularized area in between.
So you think you can go in for a above knee amputation, and the suppose the skip lesion beyond that?
Pardon,
Then
sir?
you amputate at a level, and there's a lesion above that. What will
Yes,
you
sir.
do? Amputate again?
Amputation with followed by, like sir said, we can use Fogarty's catheter to remove the thrombus from the common IV artery.
What is the management? What is the management of wet gangrene?
Pardon, sir, could not hear you, sir.
And what is the danger of doing amputation in wet gangrene? What is the danger of doing amputation in a case of wet gangrene? Dr. Mandal?
Yes, sir.
Hello?
Yes, sir. I heard your
Can you
question.
hear me? Could you understand what I'm asking?
Yes, sir.
So what is the, do you go in for amputation straight away in a case of wet gangrene? Oh, okay. Tell me, what are the indications for doing amputation in a wet gangrene?
After a level of demarcation has been established, we can go for amputation after that.
Will you have a clear-cut mark of demarcation in cases of wet gangrene?
Pardon, sir?
Will you have a clear line of demarcation in a case of wet gangrene?
No, sir. But patient is having, sir,
Then
he's having
how will
fever.
you decide when?
Sir, patient is having sepsis currently, sir, he's having
You
tachycardia,
said there's
fever.
no. So is it okay? What is the definition of sepsis? Let's come to that definition of sepsis.
Sepsis, sir, patient will have temperature either greater than 38 degrees Celsius or
What
less
is-
than 36 degrees Celsius. His counts will be more
What
than
is
12,000.
okay? Okay, hang on. What is SIRS? No, what is SIRS then? What is SIRS? SIRS?
Sir, this definition was for sir. This temperature more than 38 or less than 36, counts more than 12,000 or less than 4,000, respiratory rate more than 20 per
Right.
minute.
So okay. So you have respiration and fever and counts and all that.
Yes,
Then
sir.
what happens if suppose what is sepsis? Then what is sepsis?
Sepsis, sir, patient will
How
have
does SIRS move to
source
sepsis?
of infection.
How is SIRS different from sepsis?
Sir,
Right.
patient will have an
Go
active
on.
source of foci of infection, sir, along with tachycardia, fever, and hypotension.
Okay. So how will you manage sepsis? Is the patient having hypotension?
Not hypotension, sir, but he's having tachycardia and fever spikes he's having. So with raised counts.
Is the patient having any other organ like brain, heart, lungs, or
No, sir.
liver or kidney being affected?
No, sir.
So you think, so it is just infection, right?
Yes, sir.
Why are you calling it sepsis? Right? So now you tell me whether you'll go in for amputation straight away. How will you manage this patient? Straight away amputation?
Is about to be tested. Take no further action. This is a voice alarm.
You don't give him antibiotics.
Antibiotics, yes, sir, to decrease the septic. We'll give him antibiotics, sir.
Look, the patient is having wet gangrene. You have to make an effort to convert it into a dry gangrene before you can come take a decision. Until unless the is the limb life-threatening? It is not.
The voice is
If
breaking.
you do
sir.
amputation now, there'll
Yes,
be
sir.
some lesion above. Again, you'll have to go through it.
Yes, sir.
You can't go for amputation straight away this patient here.
Yes. You should first try to control the infection, followed by like deciding to go for amputation.
Within post of infection is sepsis.
Your voice
If
is
one of
breaking.
the organs is destroyed, then it becomes severe sepsis. It's like saying, how do you convert? What do you do to convert to?
Sir, we will give him antibiotics, initially
There's so
empirical
much of
antibiotics.
disturbance. How do you manage a case of wet gangrene?
Sir,
Will you send blood culture? Will you start
blood-
antibiotics? Will you hydrate the patient?
we will, yes, sir.
You'll send a blood culture. You'll send a tissue culture. You will
Culture, blood
get an
culture.
X-ray of his limb done,
Yes, sir.
right?
Yes,
You
sir.
will do serial debridement. All this has to be done. You can't go for amputation straight away. Sir, please, anyone else?
Sir, please,
Yes.
can I come in, please? Can I come in, please? Can I come in,
Yes,
please?
sir.
Yeah, sir, the thing is, this is a classic case of acute limb ischemia. It is an ischemic insult. It is a dying limb. That is why all these changes that we are discussing, the gangrenous part, the sepsis component, if the clinical reports are seen, the muscles are dying. So it is an emergency procedure. We cannot take it as a regular case of a gas gangrene or wet gangrene. The only reason of this limb worsening is because of there is no supply. It is an acute limb. The patient has presented to us late, and in emergency, yes, we have to give him antibiotics, everything. You have to control sepsis, but the cause of sepsis is an ischemic insult. It is not that secondary infection. So we have to open up the vessels, and I still believe the approach is it is an emergency. You cannot wait for blood cultures and everything. In such a scenario, it is an acute limb. It is a life-threatening condition, and if you see the RFTs of this patient, the counts must be somewhere around more than 25,000. The creat is deranging. You have to catheterize the patient to see it is, patient will definitely have myoglobinuria. Okay, these are the dying muscles. So the most important aspect in to save the life of this patient in such a scenario is we have to proceed with the level of amputation. The limb is absolutely non-salvageable. There is no movement, no motor sensations, no sensory. Everything is gone. There is no flow. You proceed with an above knee amputation, do an embolectomy. Within 24 hours, your patient will be normal. Secondly, if we try to convert this wet gangrene, actually it is not wet gangrene. It is an ischemic insult. Okay, sir. If you try to convert it into dry gangrene, we try to conserve the patient for another 3-4 days. We will definitely lose this patient, and he's going to end up in acute renal failure, and eventually we are going to lose this patient. So the most important aspect, it becomes an emergency. It is an ischemic limb. So we have to differentiate an ischemic gangrene, ischemic limb from the normal wet gangrene. And this patient is not diabetic. There is no source of infection other than ischemia in this patient. So
Yes.
I personally feel, as a vascular surgeon, I personally feel it is absolutely an emergency. I think Ajay sir is there. He's a very senior vascular surgeon. He's done thousands and thousands of cases. I think Ajay sir, if you can please come in, please, and uh, give your opinion on the management in such a scenario, sir.
Am I audible?
Yes, sir.
Am I audible?
Sir,
Yes,
you
sir.
are audible, sir. Please go ahead, sir.
Okay. I think I absolutely agree with Dr. Luthra that this patient is having it is not the limb saving attitude here, it is a life saving attitude here. If you have to save this patient, you have to get away with the limb here. And as far as the limb which is concerned, I may not go for a flap amputation here, but I would like to go for a guillotine amputation here. Because I still do not know that what will be the supply to that. And along with that, definitely, if you can plan through the same artery where you're opening up, you can do a thrombectomy through the same artery. It may or may not help, but probably with the guillotine amputation, you will definitely spare this patient from the sepsis. And because this patient is going to definitely go into renal shutdown very soon. If it is not there, it is going to go into renal shutdown. And that is the way that you have to go for that, apart from giving the patient antibiotics and hydration, giving the patient low molecular dextran and all those things. But this patient requires the amputation as an acute case. That is my personal opinion. Hello.
I think the verdict is very clear. Dr. Rima, do you have any doubts or any comments to get clarified with the national faculty now?
Sir, in this case, I'm still confused about what is the cause of the thrombus which in the patient. If it is not Burgess disease, then patient still does not he does not have any history of diabetes or hypertension or hyperlipidemia or no family history. Then what is the cause of the thrombus in this patient? It might be that the patient has not yet been diagnosed. Patient has come to us recently in emergency, so it's not still on. Maybe he might his investigations later might reveal that he's having hyperlipidemia or his blood sugars are normal. His BP is also normal. Maybe he will have hyperlipidemia. The cause of the thrombus is not clear still to me, sir.
But you
Fine.
get an echo done and
Yes,
you will
sir.
find the cause of source of thrombus. ECG, if you look at the ECG, I still believe that it is an embolic phenomena. Okay. And definitely he has some underlying cardiac cause. Probably he's having AF. If you monitor the patient tonight, okay, just ask
Yes, sir.
their heart rates, you'll definitely get an echo done and you'll find. And not even an echo from your routine monitoring, ECG heart rate monitoring, you'll see that the patient is in AF.
Yes, sir. Sir, can the patient if he has a thrombus in the common iliac artery, if that thrombus can go and it can
No,
form an
no.
embolus and go
The,
in the peripheral blood vessels, and then patient will have
see,
acute
the
ischemia.
source of embolus is always the heart, left ventricle. Okay. He could have ended up in a TIA stroke also. He he ended up uh, in an acute limb ischemia. The right common iliac bifurcation is occluded. So you have to evaluate the most probable cause in this case. I still believe is embolus from the heart. And it is very important to get an echo done because if still there is a thrombus or an embolus in the heart and you operate such patients, there are chances that he may rethrombose.
Yes, sir.
So we have to keep the patient on anticoagulation. And, definitely a cardiac opinion is mandatory in such cases. You have to get it documented because we are living in a, very critical world right now. Doctors are under maximum scrutiny. Okay, whether we are in government colleges or we are in private practice, so we have to document everything. And definitely, it is an emergency. You operate the patient as early as possible. Like Khanasa told that, yes, actually, the level of amputation will be, you'll right now, you'll have to go with the guillotines. You have to open up the vessels and then you can take a call, because we've not seen the patient clinically. We don't know the exact status of the limb right now, but as from the pictures, it looks that there is calf tenderness. The calf muscles are open. You have to do a fasciotomy to see the muscles, whether they are alive below knee. In case the muscles are dead, not responding to your cautery, you have the first thing that you need to do is you have to correct the, you have to do a thrombectomy in this patient. And then before that, just confirm it whether there is no embolus lying in the left ventricle.
You have to check for the cardiac status of this patient. That is very important. The second thing you have to see for the thrombophilia. Usually the thrombophilia leads to the venous thrombosis, but it can also lead to the arterial thrombosis. So you check for the parameters of the thrombophilia also, apart from the cardiac status.
And just to add to this, you if you have the CBC report of this patient, just probably these smokers, they have polycythemia. Their HB is going to be somewhere around 16, 17, 18 grams. Okay. So polycythemia is another cause of thrombus in this patient. He is a chronic BD smoker, very young patient. He's a tobacco chewer. So you, from the CBC report, you yourself can diagnose the cause of thrombus. Either you'll get an emboli AF in the echo and ECG, and you see the CBC report, his HB must be somewhere around 17, 18 grams. I feel so. It is going to be above the normal, his HB levels. Yeah.
So thank you, Dr. Rima, for taking all the efforts to present a case here. I'm sure this will definitely give you certain verticals to study up, like what are the areas you have been little weak or something. And I'm sure when there is a complex case, like today we have so many experts coming to a fair amount of directives to you. So it is a dynamic process, the treatment. See, establishing diagnosis, yes, it is a very important task. But the hand priorities are saving the limb, saving the sepsis, saving the patient as a whole. And academic interest can run along with the process of treating the patient. So diagnosis and treatment together runs along with the management in this patient. That should be the approach. And I wish you to join us sometime next week and to give an update about what happened to the patient and what is the status also. All of us are very eager to look into it so that we also get to learn and we also get to know what is happening eventually.
Yes, sir.
Yeah.
All right.
Nice
and
presentation,
maybe,
Dr. Rima. I think just go through the case again. It was almost a very nice presentation.
So good luck to you. And thank Dr. Swagta ma'am to permit you for presenting this case. I'll appreciate next week you join us for a few minutes to tell us an update about what happened to this patient.
Sure.
Thank you very much. And faculty, you can stay with us, Dr. Rima. We have another venous case for discussion. You can be part of
it. Yes.
Friends, we have Dr. Prashant. Prashant is from Government Stanley Medical College, Chennai. He is going to share his experience in the management of one of the venous cases he has managed this patient. Dr. Prashant, please introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you. Faculty, please take up. Dr. Rima, you should unshare your presentation. Dr. Prashant, you can try sharing your PPT. Do you have any challenge in doing that? Yes, we are able to see your slides. Make it into slideshow mode. Good luck to you, Dr. Prashant. Yes, everything is good. Start your presentation.
Good evening, sir, and good evening to everyone. I think my voice is clear.
You're good. You're good to go.
Yes, sir. I am here to talk about a case of varicose vein.
Do you have any challenges, Dr. Prashant?
Yes, sir. I'm sharing my slides, sir.
Yeah, we are able to see your slides.
No, sir.
You please let me know what is happening on your side.
Yes, sir. So, good evening to everyone. I am Prashant from PG, Department of General Surgery, Government Stanley Medical College, Chennai, and my chief, Professor Dr. Anandima Minute. And I am here to talk about a case of varicose vein. A 60-year-old male who is a teacher by occupation came with complaints of dilated tortuous veins in the left lower limb for the past 8 years and pain in the left lower limb for the last 1 month. History of present illness: the patient was apparently normal before 8 years. Then he developed multiple dilated veins in the left lower limb, which was insidious in onset, initially small in size and present over the medial aspect of left leg, and gradually progressed to the medial aspect of left thigh to attain the present size. It increases on standing and decreases on lying down. The pain is dull aching type, not radiating, aggravated on standing, worsening towards the end of the day, and relieves on lying down. No history of swelling, no history of abdominal pain, no history of abdominal distension, constipation, no history of fever, no history of intermittent claudication, no history of trauma, no history of prolonged immobilization, no history of chest pain or dyspnea, no history of tingling sensation or numbness in the leg or foot. Past history: no comorbidity, no history of previous surgeries, no history of similar complaints in the past. A personal history: the patient consumes mixed diet, normal bowel and bladder habits. He smokes for the past 12 years and consumes alcohol for the past 12 years. Family history: no history of similar complaints in the family members. And this is a case summary. A 60-year-old male came with complaints of dilated veins over the left leg, probably of venous etiology, involving the great saphenous vein system. Maybe my with the history, this may be due to varicose vein in the left leg.
Dr. Prashant, you go back to the first slides.
Yes, sir.
The faculty will be able to start questioning you from slides. Luther and faculty, please take over.
Can you go to the next slide, please? Next slide, please.
Yes, sir.
Chief complaints, definitely he came up to you clinic with complaints of dilated veins. Okay.
Yes, sir.
Dilated veins. He had some other symptoms.
No, sir. The patient had complaints of only dilated veins and pain complaints, sir.
Is there any difference between varicose veins and chronic venous insufficiency?
The chronic venous insufficiency, it may be also due to deep venous system involvement, but in varicose vein, it is the involvement of the superficial veins and the perforators only, sir.
See, chronic venous and varicose veins is one component of chronic venous insufficiency. If you've gone through the classification, there is a CAP classification. Okay. CAP means clinical, etiological, anatomical, and pathological. Okay. So C0 is no veins, C1 is reticular veins, C2 is varicose veins, C3 is edema, C4 are the skin changes, C5 is a healed ulcer, and C6 is an active ulcer. So varicose veins is actually a spectrum, part of the spectrum of chronic venous insufficiency. When you take the detailed history in your history of present illness, the patient will tell you, you just have to ask him a simple question. You get up in the morning, the patient is absolutely fine. Varicose veins is actually seen in those patients who do a prolonged standing job or a sitting job in today's world. Okay. The patient will tell you he's absolutely fine in the morning. There is no swelling, no discomfort in the leg. But as his day finishes, the first symptom he'll have is tiredness in the legs. The affected limb will be swollen in comparison again to the normal limb. Dilated veins is one component. That is why the patient has come to you. You have to ask the symptoms of any skin discoloration around the ankle region, the medial malleolar region, or the lateral malleolar region. Then swelling as the day ends, tiredness as the day ends. Okay. Is there any component of itching? These patients will always have itching, especially at the end of the day when their leg is swollen, the limb is swollen, they'll have those skin changes around the ankle. So this is very important. Dilated tortuous vein is not the first symptom always, although most of the time 90% of these patients will actually come with a complication. They have those symptoms of tiredness, swelling as the day finishes. So this has to be included in our HOPI.
Okay, sir.
Yeah.
Shall I proceed, sir?
Yeah. Ajay sir, would you like to come in?
So the patient is having chronic history of dilated veins, sir, for 8 years. Now he has came to the hospital due to the pain only, sir, which is frequently seen in last 1 month, which is dull aching type, non-radiating, aggravated on standing, worsening towards the end of the day, sir, and relieves on lying down. With that chief complaint, the patient has presented to the hospital, sir. and I asked no history of skin itching or abnormality. He didn't comment anything.
Fine, this is perfect. You've included all the symptoms. The patient himself says that the swelling and the pain, discomfort relieves the moment he raises his leg because the venous return has started. So this is very important.
Okay, sir.
Yeah.
Dr. Luthra, I think Dr. Khanna is in the airport. I think you should please carry on with the discussion once he is comfortable to join, Dr. Luthra. Thank you very much.
Oh, okay, sir. Fine, sir.
Will I proceed, sir?
Professor Mukesh, Professor Gabriel, Professor other senior professors would like to chip in. If you, I'll request you to come and to give your comments or ask questions if you feel like. Thank you. Dr. Luthra, please carry on with it.
Yeah, please go ahead, please.
On general examination, after getting consent from the patient, was examined in a well-lit room with adequate privacy. Patient is conscious, oriented, afebrile, hydration is adequate, no pallor, icterus, cyanosis, clubbing, or pedal edema, or no generalized lymphadenopathy. The vitals are BP 110 per 70, pulse rate 88 per minute, saturation 99% in room air. Girth and length of both the lower limbs are equal. This is the image of the patient, which is where the dilated tortuous veins are seen mostly on the medial aspect of thigh and the leg. On inspection of both the limbs, gait of the patient is normal with no deformity. Right lower limb is normal. Multiple dilated tortuous veins noted along the medial aspect of left lower limb, extending from left leg to the left thigh. No ulcer, no loss of hair, no scars or sinus, no skin changes noted. On palpation, no wound, no tenderness. Inspectory findings are confirmed by palpation. Multiple dilated veins noted along the medial aspect of left leg, extending up to the left mid thigh. Bilateral arterial pulses are present. Then I proceeded with certain test. Brody Dunderland-Bug test 1 showed rapid filling of veins from above downwards after removing tourniquet, and test 2 rapid filling of veins from below upwards without removing the tourniquet present. And modified but this test not done since the perpetrators are already incompetence by with the help which are shown which are identified in Tenderlenburg test 2. Multiple tourniquet tests are done to know the perpetrators incompetence. Morris cough impulse showed present is present in SFJ, saphenofemoral junction. Figan's test showed multiple gaps or pits noted in the medial aspect of left leg and a mid thigh, indicating the presence of incompetent perforators. On percussion, Schwartz test done on here the dilated veins impulse felt on the saphenous opening. On auscultation, no bruit. Examination of lymph nodes, no palpable lymph nodes. Systemic examination. Before that, the motor sensory system was normal in both the limbs. Systemic examinations were normal. CV, CNS, RS, pyramidal examined. The pyramidal soft, no dilated veins, no palpable organomegaly, bowel sounds are present. Digital rectal examination is normal. With this, I came to the diagnosis of primary varicose vein of left lower limb with involvement of left great saphenous vein, left saphenofemoral junction incompetence, and left perforator incompetence, which is below knee and above knee. And according to CAP classification, it is a C2S with the etiology of primary, and anatomical is due to superficial veins and perforators. And the pathophysiological behind is reflex.
Okay, can I come in, please?
Sir?
Yeah. See, Can you please show the picture of the leg, left leg? Can you, if you zoom the picture, you can clearly, definitely you can see those dilated veins along the medial aspect. But
Yes,
can
sir.
you see those changes around the ankle? There is discoloration. If you compare it with the right leg, you'll classically find this difference. His right leg will absolutely be normal. The skin texture. These are those skin changes around the ankle that we usually miss. Even the patient misses. This patient has come to your surgery department because he's seeing those dilated veins. But these skin changes have started long time back, and he has always visited a dermatologist. He's been taking those anti-allergic and applying those steroid creams. Okay, so this is what I was talking about. Now, because in this picture, your diagnosis as per the CAP classification C2 is not right. It is, he's got lipodermatosclerosis around the ankle. Ajay sir is there. I think before he takes his flight to Calcutta, sir, please, you are the better person to guide them, sir, please.
Yeah. Okay, when you say it is a chronic venous infection, from your point of view, you can say that if the disease is beyond C2, if it is C3, 4, 5, 6 is there, then that is labeled as the chronic venous insufficiency. And in this picture, what you are showing here, definitely there is a pigmentation is there. There is evidence of some lipodermatosclerosis is there. So it is not C2. At least it will go to C4. Yeah, so there is pigmentation is there, and there is also thickening of the skin which is there. So they are all going to C2. It is not C2. Now, how did you carry out in this patient the tendon mug test?
Sir, the tendon
How
bug
did you
test.
carry out?
Yes, sir. Before doing test, the patient is made lying down, and the entire the superficial veins are milked, and then elevated, and tourniquet is applied. Then the patient is made
Where
to
do you apply the tourniquet?
at the
Where do you
SFJ
apply the tourniquet?
SFJ junction. SFJ junction, sir.
So how do you find the SFJ junction?
To find whether due to incompetence of SFJ or due to perforator, sir.
No, but how do you anatomically find where is the SFJ junction?
It is some books says that 2.5 centimeters below and lateral to the pubic tubercle, and some books says that 4 centimeter below and lateral to pubic tubercle, sir.
Pubic tubercle.
Yes, sir.
How do you find the pubic tubercle?
By flexing the leg, by following the adductor longus muscle, the attachment is noted as a pubic tubercle.
So you do not apply at the saphenofemoral junction, you apply below the saphenofemoral.
Yes, sir. Just below.
Okay. Not at, but below that. No?
Okay.
Yeah. Then what you do?
Then the patient is made to stand, and after releasing the tourniquet, there is a sudden filling of veins from above to the below downwards.
So you want to do this test 2 times? Tendon mug test?
One, sir. And the test.
No, because you have to demonstrate the tendon mug test 1 and tendon mug test 2.
In tendon mug test 2, I don't release the tourniquet, and the patient while standing.
So that's what I'm asking. That are you going to do this test twice? Because if you immediately open that, then you cannot demonstrate the tendon mug 2 out.
So before releasing if dilated veins present, the test 2 is positive, sir.
Yeah, so you wait for some time, do not open the tourniquet immediately.
Yes, sir.
And then you can see that there is a perforator incompetence there.
Okay, sir.
And then you wait for some time, and then you open that, and then you see the filling of the vein.
Yes, sir.
From up down. There's a rapid filling of the vein from up down.
Okay, sir.
How do you do the multiple tourniquet test?
I applied tourniquet test in the mid thigh, above the knee and below the knee. And before that, after milking, I have tied, and the patient is made to stand up. The where the perforators incompetence are present, I can see the dilation of veins only in that particular confined areas.
No, but you have to open the tourniquet. Is it? You have to open the tourniquet to find out where it is.
Yes, sir.
So how will you open that? How will you open the tourniquet?
So from below, sir, from below, each tourniquet will be released, sir.
Yes.
At which
Below
level?
you will start it. Yes. Okay. Yeah, it has to be started. The lowest one has to be opened first.
Yes, sir.
Okay. Now, in which test you have not to empty the veins? Out of all the various tests which is there, in which test you do not require to empty the vein?
In Pathis test, sir. The Pathis test consists of two types. Only Pathis test and the modified Pathis test. In Pathis test, it is a subjective type where the patient bandage is applied entirely after milking, and the patient is made to without milking, and the patient is made to walk. First, initially stand and then made to walk. The patient will be able to tell the pain, severe cramping pain over the entire leg. And in a modified Pathis test, it is a objective type where the dilated veins along with pain is noted, sir.
Usually, you
here,
do not carry out the Peripheral test, no? Because
yes,
you have to put the asthma bandage for that. No? That is very cumbersome.
yes,
So better to carry out the modified Peripheral test. No? And this is a test where you have not to empty the veins. Now, can you tell what is the normal venous pressure at the ankle joint in the standing position?
around 100 mmHg, sir.
Okay. And what is the ambulatory venous pressure?
300, sir.
How much?
300, sir. While walking, the pressure increases
No,
up to
no.
300.
No. Ambulatory venous pressure. Normal ambulatory venous pressure is?
100, sir.
No. It is the standing position. Pressure is 100.
Yes,
but
sir.
once the patient starts walking or doing the tiptoe exercises, then it comes down to 20 to 30 millimeter mercury. And this is the main pressure. The ambulatory venous pressure is the main pressure which decides about the venous hypertension in that area. And that is related to the venous ulceration. So if somebody has got a high ambulatory venous pressure, then he is more likely to have the venous ulcer. Okay. So it comes down to 20 to 30 millimeter mercury. That is the normal pressure. Normal ambulatory venous pressure. Okay, Dr. Luthra, you can take over.
Yeah, one more thing. I just forgot to mention in the history. Probably it should have been mentioned in the past history that there was no history of deep vein thrombosis in the past in this patient. Now I want to ask you,
Yes, sir.
how do you differentiate clinically between a post-thrombotic syndrome leg, okay, and primary varicose vein? In your diagnosis, you mentioned that etiology is primary. So you've ruled out DVT, but how do you differentiate a post-thrombotic syndrome limb from a primary chronic venous insufficiency limb clinically?
So venous called claudication, sir.
I said clinically, not with the history. You must have read in ASDAS, it's very nicely mentioned, inverted champagne bottle sign. So, like in your diagnosis, you said it is primary. So probably we've ruled out there was history of DVT in this patient because our line of management completely changes if it is a post-thrombotic syndrome. The leg will appear as typically as an inverted bottle of champagne. Okay. So that is one thing just wanted to tell you. Rest Ajay sir has already mentioned everything. Okay. So now you can proceed. What is going to be your line of management now? What is your confirmatory? You've done all those Trendelenburg tests. Yes, they are very important. How are you going to confirm your diagnosis now?
My investigation of choice is ultrasound or a duplex cancer.
Okay.
With that, I am going to see the patency and the flow and reflex and competence, whether it is competence or incompetence. With that, I am going to confirm the diagnosis, and I will then further proceed with the management.
Patency or what are you going to check?
Whether the deep veins, the superficial veins are involved, is incompetence of perforators.
Okay. And how will you differentiate between chronic venous insufficiency and deep vein thrombosis clinically?
In deep vein, severe thrombing type of pain will be seen, sir, with the edematous, and the patient is not able to walk.
No, walking doesn't have anything.
Claudication
Okay.
pain will be severe, sir, and it will
How
be.
do you differentiate? See, again, how do you differentiate venous and arterial claudication?
For relieving the patient, instead of walking or standing, the patient lies down, which will be immediately relieved in deep vein thrombosis, and it takes time, more than 30 minutes in case of a venous claudication, sir.
No. Can you please come back? You didn't mention about the arterial status.
Yes, sir. The pulses are normal, sir, and
Normal. Yeah, fine.
yes, sir. Yes, the pulses are normal, and no tingling and numbness sensation felt on both the lower limbs, sir.
Absolutely right. So the deep venous thrombosis in DVT, in an acute DVT limb, you will always have that calf tenderness. There is going to be swelling depending on the deep veins that are involved. If the islet component is there, the swelling is going to go up to the thigh. The patient will present to you with sudden onset of swelling. Okay.
Yes, sir.
So it is acute condition. So fine, you've done the Doppler. So what is your next line of management for this case?
Yes, sir.
The
Generally,
junction is incompetent.
yes, sir.
Scenario one.
Yes,
And
sir.
in second scenario, the junctions are fine. There is only perforator incompetence. What is your line of management?
Okay, sir. Initially, we will proceed with ungentive management, sir. If the patient is treated as OP with minimal pain, we can use compression garments with class 3 around 30 mm sir, and elevation of
It is
pelvis.
class 2. 22 to 32 mm is class 2,
So
not
25.
class 3.
Yes, a class 3, 25 to 35 mm.
Class 2 is more than enough
Yes, yes, sir.
for these patients.
Okay, sir.
Okay. Yeah.
Dressing, if the ulcer is present, we can help with the dressings and a prophylactic.
What kind of dressing?
Uh, so for ulcer management, daily if slough is present, debridement of ulcers. Uh, if you are suspecting infection at the or the ulcer, we can send for pus culture sensitivity, limb elevation with bandages.
Uh, Dr. Prashant, you are from Stanley Medical
Yes,
College,
sir.
Chennai.
Yes, sir.
You have one of the best vascular departments in the country,
Yes.
in Stanley. So, have you ever visited that department?
Yes, sir. 2 weeks postings, peripheral postings, sir.
Posting is there. So, is it over or
Yes,
you are yet to go
sir.
there?
Completed, sir.
So, you must have heard about and seen about four-layer compression dressings that they do for their venous ulcer patients.
Yes, sir.
Like Ajay sir just mentioned, the main cause of chronic venous insufficiency is ambulatory venous hypertension.
Yes, sir.
A normal dressing is never going to heal the ulcer. You have to treat that venous hypertension.
Okay, sir.
You either remove the reflux And for that ulcer, you must have seen them doing 4-layer dressing, starting from the base of the toes, going up to the knee.
Yes, sir.
So that is the answer. You need to do compression, 4-layer dressings. No?
Okay, sir.
So you must have seen that in vascular department there.
Yes, I seen, sir.
So yeah, then why didn't you? Okay, that is managed by health, sir. How are you going to manage the reflux?
Sir.
How are you going to manage the reflux in this patient?
So if SFJ reflex is present, I will then proceed for surgery, sir.
How will you manage?
Surgical management, yes, sir. With that Trendelenburg procedure, I will proceed with the plus ligation of SFJ junction.
Online class. Man, global. एक minute, hold कर. No, there are multiple options. Okay, we've been doing open surgeries, and now we've come to minimal invasive surgeries.
Yes, we can do
for varicose veins.
Laser therapy, foam sclerotherapy method,
Exactly.
endoscopic laser.
Have you data?
Sir?
Do you still believe that open surgery is best? What is the difference between minimal invasive laser surgery and open surgery?
The less scar, the patient feels more comfortable in recent minimal invasive.
I think the best person is there. Ajay Sapliko for the management surgical options. Please.
Tell what are the various options available for the treatment of the varicose veins?
Endovenous laser therapy is there, sir.
Can you hear me?
Endovenous laser therapy, sir.
Can you? No, tell the various options available for the treatment of the varicose veins.
Okay, sir. Initially, adjuvant therapy. Then, if then can be proceeded with surgery, either open technique or minimally invasive. The minimally invasive consists of a laser or endoscopic ablation method or foam sclerotherapy. Recently, sclerosant agent can be used, sir. In case of only
Okay, you start with the lifestyle modification.
Yes, sir.
Okay. Can you hear me?
Exercise, counseling the patient, advising the limb elevation, compression to stop pressing.
Yeah. Then the medical treatment. You know what is the medical treatment for veins? Can you hear me?
Since voice not clear.
Hello. Hello.
Yes, sir.
Medical treatment for the varicose veins?
If comorbidity is present like diabetes or hypertension, must treat the cause. Or in case of obesity, reduce with the weight.
Yes, if there is any comorbidity there, we are going to correct that.
Yes, sir.
But any specific treatment which is there for the varicose veins? Have you heard the name of flavonoids?
Yes, sir.
Hello.
Diaphragm.
You heard the noise? Yeah, diaphragm is one of them. Yeah. So you can use the flavonoids. You can use the calcium oxalate for them. And the third treatment is the compression side. That how much pressure compression? Hello.
So, yes, sir.
Is my voice coming or not?
Yes, sir. Yes, I can hear you.
So, there are different gradings of the compression is there.
Yes, sir.
So if the patient
Class.
has got the 2 degrees, then what is the compression you are going to give?
Either class 2 or class 3 compression stock.
Wait, then in that case you are going to give the class 2. Okay. But if there is CVI is there, then you have to increase the pressure of C3.
Okay, sir.
Right?
Okay, sir.
Okay. Okay. Then the fourth treatment which is there is either the open surgical treatment or minimal invasive treatment or non-invasive. Sorry, open techniques.
It's a Trendelenburg procedure with the first ligation of SFG junction.
Very good. Yes. So you only do the first ligation there in the Trendelenburg operation?
Yes, sir. The Trendelenburg procedure consists of only ligation of flush ligation of SFJ, sir. But additionally, we can remove the great saphenous veins up to the knee joints.
So you are only doing anything for the tributaries?
Yes, sir.
You know what are the various tributaries which are draining in that area?
Sir, 6 tributaries are ligated here, sir, usually. Which is
At
on
least 3.
6.
Yeah.
6
Okay, at least 3. What are those 3 main 3 which are there?
The pudendal vein.
Which pudendal?
It's a superficial external pudendal vein, distal external pudendal. On the lateral side, superficial epigastric vein, superficial circumflex iliac vein. Distally, the posterior and medial thigh vein and accessory veins, accessory anterior saphenous veins are ligated.
So that is a part of the Trendelenburg operation. That you have to at least ligate 3 tributaries: pudendal, circumflex iliac, and the epigastric.
Okay, sir.
Okay, and then you add the stripping in. Up to what level you are doing the stripping?
Up to the knee joint, sir.
So why not below that?
Because there's a more chance of saphenous nerve damage.
So you can damage the saphenous nerve below the knee.
Yes, sir.
So that is why it is only done up to the knee joint only. Okay. What are the other surgical options?
Endovenous laser therapy.
No, surgical options. Open surgical option. So one is a Trendelenburg operation. What else?
And stab avulsion method for perforators incompetence.
Stab avulsion can be done, or many phlebectomies can be done.
Yes,
then in the case of perforator, you can do the subfacial ligation.
Yes,
You know what is the name of the subfacial ligation?
Trivix, trans-illuminator powered phlebectomy.
No, that is the phlebectomy, subfacial ligation. That is the Linton's technique.
Using a
Subfacial
camera,
ligation.
yes, sir. Using a camera, the incompetent perforators are inside the deep fascia are identified and ligated.
No, that is different. I'm calling only about the open surgery. So that is the endoscopic surgery, what is called a SEP surgery. Subfacial endoscopic perforator ligation. No.
Yes, sir.
That is different. That is the endoscopic surgery. But you can do the open ligation also, what is called Linton's operation. And then there are saphenous sparing surgery.
Rods and a cocket procedure can be done, sir.
Yes, you can do that, yes.
Here, the multiple incisions and ligations above and below the fascia are done.
Okay, now tell about the minimal invasive techniques which are there.
Laser therapy, sir, which is endovenous laser therapy. Here,
You divide into two types.
yes, sir.
One is the tumescent, another is non-tumescent. You understand what is tumescent?
Yes, sir.
What is tumescent?
Yeah, it is more analgesic and to avoid burns surrounding the structures during the surgery.
So you make the swelling around that particular area. No?
Yes, sir.
Okay. So you inject the normal saline along with other things which are there, so that you produce a tumescent around the vein there. So that the vein is compressed, and when you are firing in that area like the laser or the RFA, it is not transmit to the nerves and the tissue around that and the skin also. So all these are called as a tumescent anesthesia. So what are the various types of tumescent techniques which are there? You can do the laser. You can do the RFA.
Yes, sir.
Any other you know? Any other technique you know? You can do the microwave ablation. You can do the steam ablation. Okay, these are called as the tumescent type. What are the various non-tumescent type?
Using of
What are the various non-tumescent type of the techniques?
Sclerosant usage venous glue, sir.
Yeah, you can glue in that area. Okay. Or you can do what is, you know what is MOCA, M-O-C-A? MOCA. Okay, this is called a mechanico-chemical there. Mechanico-chemical ablation, which is there, that is called a MOCA.
Okay, sir.
Or you can do a sclerotherapy. So out of these three, the most popular is the sclerotherapy. But the problem with the sclerotherapy is that there is a high chance of recurrence here. So usually you can do the frontal sclerotherapy, but it is mainly reserved for the recurrent disease and the small vessels, which is disease. The sclerotherapy.
Okay.
And then there is a non-invasive. You know what is the non-invasive variety of the treatment for varicose veins?
Teflon method.
That is called as HIFU. HIFU is high focus sonography. Ultrasound, high focus ultrasound.
Okay.
Okay, there you are not giving any incisions there, but only with the help of the ultrasound, you are blocking the vessels. That is the HIFU technique. Okay, so these are the various treatments which are there for the treatment of varicose vein. And majority of the patients will require a combination of the two. They will require the lifestyle modification. They will require drug treatment. They will require the compression treatment. And they will also require the minimal invasive techniques. So what is the plan in your patient?
I prefer endovenous laser therapy for this patient, sir.
Have you ever seen that?
Yes, sir.
Which laser machine is used?
ND.
NDAG is not used for this purpose. It was some other laser which is used.
Diode laser.
Yes. Diode laser. Okay. You use a diode laser for that. NDAG is used for which type of the treatment?
For hemorrhoid, after surgeries can be done, sir.
No, in the varicose veins. In the varicose veins, NDI is used in which type of the treatment? Okay, when you are treating the reticular veins or the telangiectasia, which is there, procedure is called as a CLACS. CLACS. Have you heard that name? CLACS?
No, sir.
The CLACS stands for the cryolaser and cryosclerotherapy.
Okay.
So there you use the NDI laser. But here, for the endovenous ablation, you use the diode laser. And what is the wavelength of that diode laser which is usually used?
1470 nanometers. Sir.
Yes, which is 1470 usually.
Yes, sir.
But now we have got the higher one also. Okay, even you can go up to 1920 also.
Okay.
So 1470 is the most popular one.
Okay, sir.
Now, when you're using this laser, what precaution you have to take?
We should proceed for each and every centimeter 60 joules, not more than that, sir.
Where you will put the tip of the fiber which is there? When you are introducing that, where you will put the tip of the fiber?
5 centimeter away from the point, sir.
5 centimeters is too much, no? Which is 2 centimeters. No?
Okay, sir.
5 centimeters when you are putting the glue. In the case of glue, you have to put 5 centimeters, but here it is only 2 centimeters. So it will be 2 centimeters away from that. Why you put 2 centimeters away from that? What can happen?
Skin burns. Damage to the vessels nearby, sir.
No, what can happen because of that? There is a specific term which is there.
SFJ damage is prevented, yes, sir.
No, you want to damage the SWJ, no?
At the junction.
But something can happen. Have you heard the E-HIT, EHIT, or ablation-related thrombotic complication? E-HIT is, which is endovenous heat-induced thrombosis. Okay, so if you put the tip of the fiber very near to that of the SFJ, there may be thrombosis which may go into the deep veins, into the femoral vein.
Okay, sir.
That is the reason that you keep at least 2 centimeters proximal to that.
Okay.
So that's why E-HIT or ablation-related thrombotic complication. Right?
Okay, sir.
What other things, what complication can occur because of this, the laser?
Uniform distribution, if we didn't notice, recurrence is more common, sir.
Recurrence, yeah, if you do properly, recurrence is very less with the laser. But that is also, if you are not properly laserizing the vein, there can be recurrence may be there. And then there can be other complications like that, may the patient may have the neuropraxia, the patient may have skin burns, the patient may have pain because of that. So all those complications which are there with the endovenous laser ablations or even with the endovenous RFA also.
Okay.
Dr. Luthra, you can take over this slide. Dr. Luthra?
Yes, sir.
Yeah, you can take over now. Yeah.
So you've explained him everything. You've taught him everything. So I don't think so. Something is left regarding management of operative management of varicose veins. So I think we need to give all the platter options to our patients. And we also need to know what are the, recurrence rates, because see, varicose veins is one of the most commonest diseases that we encounter in our life. Okay. Most of our patients coming, you'll see hundreds of patients. So it is very important to decide, like we need to start from conservative line of management, medical management, And then, yes, those patients who do not respond to conservative, who are not willing to wear those stockings, compression stockings, and take those medical managements, intervention is one of the best options we have. And then we have to get down, because the biggest issue with varicose vein surgery or any minimal invasive surgery treatment for varicose veins is recurrence. And the only thing I wanted to add to what Ajay sir has just explained in detail, the different modalities we have for the treatment of varicose veins is a USG guided procedure. Now, everyone is doing, even a plastic surgeon, even a radiologist, everyone is doing varicose veins these days. So the biggest difference is a USG guided procedure. You get those markings by a radiologist, they'll mark perforators for you. Okay. And then they'll mark the junction also. The most important thing in a minimal invasive technique to treat varicose veins is, you need to see the junction. You have to be proximal to that junction. And if you are very well trained in USG, so I would suggest to all the general surgery PGs who are coming up, so whenever you're doing a minimal invasive technique, you do RFA, you do laser, you do venacine, whatever you want to. So you need to be, very perfect in scans, radiology. So that is one thing that I want to add, because doing a blind minimal invasive procedure for varicose veins, you may either end up, you may not ablate the vein properly, or you may enter the deep venous system, and that leads to DVT and pulmonary embolism. We've seen patients dying on table. It's very common. People who are not aware of scans, and in case your catheter goes into the deep venous system, the moment your patient comes out, within 48 hours, your patient can, die because of PE, because you've ablated the deep vein and the thrombus has directly gone into the lungs and caused pulmonary embolism. So this is one very important aspect of minimal invasive treatment for chronic venous insufficiency, varicose veins.
Thank you, Dr. Luthra. And Dr. Prashant, do you have any doubts to be clarified with the national faculty here?
No, sir. Thank you very much.
Thank you. Faculty, others, anyone would like to give their comments? Nishi, sir? Kanna sir is back. Sir, you're boarding the flight, sir. Your flight is delayed for 10:30, I was informed. You're muted, sir. You're muted, sir.
Yeah, the flight is delayed by half an hour, yeah.
Okay.
So
Anyway, that made
just on
our
the
student
boarding
lucky
point,
to
right?
have you.
Yeah. Right.
Thank you, sir. Sir, any other issues, sir? Can we call a close for the evening, sir?
Yeah, I think so, yeah. We should, yeah.
Thank you, sir. Thank you. Nishi, sir, anything else from your side, sir?
Oh, sir. Thank you, sir. Good night, sir.
Professor Luthra, I think we need to hear from you closing comments, and then we'll call a close.
I think both the students presented the cases very well. And yes, we learn. And thanks to Ajay sir, and especially Kanagaval sir, you called me yesterday. It's my privilege, and I'm honored to be part of such wonderful students. And I hope, see, we all grow and learn, and to have stalwarts like Ajay sir, Nishikant sir, it's a privilege. And I wish all the best. And for any, information regarding any doubts regarding vascular diseases, I'm always available. Any of the students can contact me or anything. So always available. Thank you so much once again, sir, for giving me this opportunity. And